disabilities. We're going to have different speakers speak on different aspects. This Succeed Africa is a research project that involves 4 African countries: Malawi, Nigeria, Sierra Leone, and Zimbabwe, in partnership with the London School of Hygiene and Tropical Medicine. And basically, Succeed Africa builds on the principles of co-production and South-South partnerships. And the plan is to establish regional centers of excellence in research and policy in psychosocial disabilities, focusing on schizophrenia, bipolar affective disorder, and other psychotic conditions. You'll be hearing from our speakers. And like I mentioned, we have at the lead, the CEO is Dr. Julian Eaton from the London School. He has a long 15-year history implementing mental health programs, and he has worked in all the countries that are involved in this research project. We also have with us an international research director, Professor Tom Shakespeare from the London School, who has a lot of experience with co-production. And then there are the 4 PIs, and I'm one of the PIs. We have Dr. Rebecca Liska from University of Makeni, Sierra Leone, who's the head of Department of Psychologist. We have Dr. Anthony Sefasi, another PI from University of Malawi, from the Kamusa College of Nursing. And we have Associate Professor Dixon Chimbanga, who is also one of the most highly cited global mental health researchers in Sub-Saharan Africa. And he's both at the London School and the University of Zimbabwe. And then you have me. My name is Olayinka Omigbodu, and I'm a professor of psychiatry and also the provost of the College of Medicine, University of Ibadan, and I'm leading the Ibadan team. On that note, I'm going to hand over immediately to our research director, who is Professor Shakespeare, and he's going to take us through an overview of intro into plans, partnerships, and scope. And then all other speakers will come forth as we continue this launch. Thank you very much and welcome once again.
Thank you very much, Professor Olayinka. That's so welcoming for us and everybody here. So we're really excited about this Succeed program because it's about co-production. It's about co-production with people with psychosis in Africa, and we hope that the impacts of it will be felt far beyond these 4 countries. We want to build up co-production and community-based responses to the challenges of psychosocial disability so that people can be included and on this Human Rights Day realize their rights. Next slide, please. So we have 3 pillars of work. The first pillar of work is research. Sorry, thank you for the slide. We should note, obviously, that it's funded by our friends at the Foreign Commonwealth Development Office, for which we're extremely grateful. We have 3 programs of work streams: research, capacity building, and uptake. Our objectives are to respond to the challenges that people with psychosocial disabilities, particularly psychosis, face, and develop a multi-sectoral care and support package. We want to start with community-based rehabilitation, but go beyond it to think about all the things that people need to flourish and live well in community. And we want to create a body of work around co-production, modeling best practice, challenging stigma, and in particular, building the capacity of experts by experience. We feel that there's less co-production in mental health work in Africa, and we want, with our colleagues that you're going to hear from during this presentation, to create this cohort of researchers with lived experience. Next slide, please. So we will, in our research work stream, develop a theory of change approach. At the moment, we're conducting systematic reviews of what works in things like services for people with psychosocial disabilities, co-production, and CBR in Africa. So with this review of the evidence, we'll know the best scientific knowledge about what is already happening. We will then go through a theory of change approach in each country where people are understanding what creates the outcomes and outputs that they need. And some of that theory of change will rely on assumptions, and we need to test those in formative research in year 2 to fill those gaps. Then, based on what we found, based on our capacity building research, based on our reviews of the different countries, we will be able to create a package of care, always in association with people directly affected. And that's what we're going to test out. First, we're going to do a feasibility study and then an RCT across these 4 countries to understand how it works, if it works, why it works, and what the impact is on people with psychosocial disability. Next slide, please. But just as important, the capacity building work stream, which is led by Ritska Kuma, our colleague at London School. And this is about building capacity for participative, co-produced mental health research. So we're already doing webinars about things like systematic reviews. We're going to continue doing this, very much bringing together experts by experience from our 4 countries and in the UK, and experts by profession, so that we can all learn together about evidence-based, co-produced mental health work. And we want in this process to build up user organizations in these countries, so they are there to collaborate in research policy and practice in future. Next slide, please. And the third element is uptake. We need, as we've already identified, to create greater understanding, to challenge stigma, to engage all the stakeholders from WHO to experts by experience to national governments to do better, more evidence, more networking, more inclusion of people with psychosocial disability, and above all, more community understanding of how they can enable people with psychosocial disability to play their role in families, in communities, and in society. So those are the 3 strands. Next slide, please. And I need to now hand over to Anthony Safasi in Malawi, who's going to explore why we need better psychosis services.
Thank you so much, Tom, and welcome again to everybody. I am Anthony Safasi from Malawi. I'm the principal investigator for the Malawi team. And I will take you through psychosis itself and what it is and how it affects everybody else. So psychosis has 2 major problems, as we understand. The first one is that it brings about disability in individuals. And this disability makes people not to work back at their level of functionality, like it reduces your level of functionality once you've been attacked by it. So that's one problem. The other problem is that it does cause stigmatization and obviously discrimination because of the disability that it comes once you've been attacked by psychosis. People tend to discriminate against you, and that already affects your social standing. You lose your ability to function in a social system, particularly like in Malawi, for example. When individuals have suffered from psychosis, people tend to stigmatize them by thinking that either they've been bewitched or in fact they were trying to play some magic that has not worked very well. And thereby, if they're seen in the society, they are denied of social services, various social services, including the access to medication. And this is our concern. So therefore, we will try in this research project to make sure that we understand from people who suffered from psychosis, their concerns, but also try to address these concerns from a different perspective from the 4 countries. So that's what we want to try and do in the Succeed project. Thank you so much. I will hand it over to Rebecca in Sierra Leone.
it looks like we may have lost Rebecca. So maybe we'll be able to hear from her in a little while. Oh, Rebecca, are you there? Looks like we can't hear you at the moment.
Having some challenges. Okay, but I think.
Please go ahead now. We can hear you,
Rebecca.
Okay, sorry about this. Okay, I am Rebecca Esliger, the ID for Sierra Leone at the University of McKinney. As according to what Tony have already said, the need for services for psychosis is eminent in Sahara Africa, as the level of public knowledge is poor and calls for further public enlightenment. What was thought to be mental health ignorance has also been blamed for poor mainstream service utilization. In many low and middle income countries, traditional and faith healers provide care for the bulk of patients with severe mental challenges because of their abundance. The synchrony of their views with their local communities in regard to the causation and treatment of these disorders and scarcity of mental health specialties. In Sierra Leone, most people seeking mental health care first visit a traditional or spiritual healer. However, even alternative care can be inaccessible to many. People with psychosis are also among the most likely to be excluded from developing interventions such as cash transfer schemes, disability mainstreaming in education, and even humanitarian response, despite repeated calls by the WHO to target people with mental challenges as a vulnerable group. Moreover, psychotic conditions have not received the attention deserved within development programming, given their long-time nature and how difficult they are to manage within low resource settings. We need to improve services for psychosis because people with psychosis and their families are among the most marginalized and vulnerable groups in society. The individuals with psychosis have a high risk of experiencing violence in my country, poverty, homelessness, incarceration, and unemployment. I believe with Succeed Project's intention to generate new knowledge on co-production for mental health research and modeling best practice in disability inclusion, addressing attitudinal barriers among key stakeholders, and building the capacity of experts by experience to engage meaningfully in mental health research and policy is the best opportunity to address these debilitating mental challenges. And it's also a way to fulfill the Leave No One Behind, which is a core principle of the 2030 Sustainable Development Agenda. And that cannot be realized unless people with psychosis, their families and communities are empowered to advocate for their needs and address critical gaps in care and support. Thank you, and I hand it over to Olainka. You should be connected to mental health. Mental health.
Good afternoon, everyone. I'm Arturo Olainka Omowi, a peer researcher and also a medical laboratory scientist.
Go to mental health.
I'll be speaking on co-production, best way on research and psychosis. Thank you for listening. So firstly, we have three major points in this statement: co-production, research, and psychosis. So I defined the first one, co-production. Co-production is a meeting of minds coming together to find a shared solution, that is, they collect data to see to the end result of a problem or solving a problem. While research is new ways, new hypotheses in finding a solution to a problem in a study. Then psychosis is a general impairment of thoughts and emotions. So I go straight to the main task now, co-production, best way for research on service on psychosis. So co-production is one of the most pressing issues. That is the means of solving pressing issues in research in psychosocial disabilities. That is, we have pressing issues not involving people with lived experiences, that do not carry them along in the majority of the research being carried out. So, but with co-production is a very good approach in tackling impending issues affecting people with lived experiences. Then it also allows for new ways of providing solutions and answering questions that seem difficult for people with lived experiences. Then it bridges the gaps and for a gap of knowledge quest for people with psychosocial disabilities, especially the peer researchers. But there might be some times, maybe they have some question about themselves, maybe their self-esteem, but when they sit together with stakeholders, that's when we talk about production, they sit together, they share ideas, and they bring about the solution. Then also, it's an approach that is co-production, best way in research and service on psychosis. It's an approach where people with lived experiences and people with professional experiences work together as equal partners. And they work together with that opinions from peer researchers are being used. It's been paramount. That's the way we talk about making them equal partners, that equal production. It's been paramount, and also co-creators. Also, co-production serve as a platform of advocacy for justice in areas where people with lived experiences might have been abused, thus creating avenue for establishment of good policy for equal rights to live comfortably in the community. And also, co-production has also played an important role in healthcare services in the high income countries. But there's been little of nothing to talk about in the low middle income countries, that is the LMIT. So, but bringing co-production into the view now, it also gives rooms for more policies to be made to allow for people with lived experiences to have equal rights to live comfortably in the community. Thank you.
Wonderful. I love Yinka's thoughts on co-production, her definition as a sort of coming together of minds. And I'm really grateful that we've all been able to come together today to celebrate this launch. My name is Grace Ryan. I'm a research manager for Succeed based at the Center for Global Mental Health at LSHTM. And I'm an early career researcher. My PhD research focuses on the involvement of people with lived experience in mental health program evaluation in sub-Saharan Africa. So I was really excited to read back in 2018 that the most recent Lancet Commission on Global Mental Health declared we are in the midst of a fourth shift, a fundamental fourth shift in global mental health toward a principle of nothing about us without us in this field. But I would contend that maybe we're still at an early phase of the shift, particularly in terms of involving people with lived experience of mental health conditions in research. So 2 recent systematic reviews of the published literature from low and middle income countries have identified only one confirmed example of the involvement of people with lived experience of mental health conditions as partners in mental health research and not just as research subjects. And as Yinka just highlighted, while co-production and user-led research have had a transformative effect on many services in high-income countries and can also help to overcome some of the methodological challenges that we face in mental health research that I've faced in my own research, Succeed offers an opportunity to explore the sort of impact that this can also have in lower resource settings. Now, what impact are we hoping to see? I'm going to hand that over to Lloyd for thoughts on the more holistic direction that we'd like to see mental health research and services go in the future. So on to you, Lloyd.
Thank you very much, Grace. Hello, colleagues. Thank you very much for joining us as Succeed on this momentous occasion as we announce our intentions towards improving the life and welfare of people with psychosocial disabilities. And to that end, we might be cognizant of the fact that there are so many challenges that have been highlighted as being found in the field of the management of people with psychosocial disabilities. And to that end, I would like to talk about what we call enhanced community-based rehabilitation. But before I do that, I would like to refer you all to the United Nations Convention on the Rights of Persons with Disabilities, which speaks in no uncertain terms towards the holistic management of impairments caused by both the disabilities as well as the barriers created by the society around people with psychosocial disabilities. we would like to know that the Global Mental Health Society has been heavily criticized, and rightfully so. This is because we have largely pursued a biomedical perspective at the expense of the holistic nature of the life of people with psychosocial disabilities. And for that reason, we have to remedy the situation by pursuing enhanced community-based rehabilitation. When we speak of community-based rehabilitation, we are essentially taking a leaf out of the Alma Ata Declaration, which speaks of rehabilitation of people with disabilities with their communities. And in this case, as Succeed, we are saying we need to promote and enhance the welfare of people with psychosis, their families, as well as their communities. This is a noble attempt on our part to address the exclusion which people with the psychosis suffer in the societies. They suffer mainly because the barriers that are in the society have not been addressed holistically, and for that reason, we need to come together favoring a multi-sectoral and multi-stakeholder approach, which then brings together different actors from different facets of life to see how best we can amplify the voices of people with the psychosocial disabilities, such as psychosis. When people with psychosocial disabilities are excluded from the mainstream economic, social, and even political activities, it means they're essentially being left out and behind of everything. And as my colleagues has already highlighted, we need to move together towards our 2030 Sustainable Development Goals. And for us to gravitate towards that mark of sustainable development goals, it means we need to make sure that people with psychosis themselves, they do not become, they do not sit in the terrain while other people take center stage in matters that affect their lives. Therefore, as Succeed, we are saying that by pursuing community-based rehabilitation, we'll be able to converge the voices of different actors that are found in institutions such as health, institutions such as education, even those matters that affect their livelihoods. You may want to understand that our sadness also comes from the realization that one of the most recent systematic review publications of 2016 highlights the fact that in almost 36% of United Nations member states, they do not allow people with the psychosocial disabilities to vote. And that on its own is injustice of an unspeakable magnitude. And we are saying as the global mental health community, we cannot allow that to go on, to have a situation where there are no equal grounds for people to participate. Therefore, we are hoping that by bringing together our voices, we will be able to level the playing field so that the welfare and livelihoods of people with psychosocial disabilities are well enhanced and protected. We must keep in mind that we've got numerous frameworks which also articulate very well the inherent self-worth of every individual. And to that end, we are saying, as Succeed, we need to promote and safeguard the rights of people with psychosocial disabilities, such as psychosis. But this is not a one-man's race, which we say we can do as researchers only. And that is the reason why we are saying the families need to be involved, the community needs to be involved, so that we are able to alter the terrain of mental health research and care. When we come together with our stakeholders and partners like we do today and marching forward, we believe that we are going to be able to come up with the research and the mental health care packages that are, first of all, feasible to the local African communities. We also want to make sure that these interventions are acceptable within these local African and middle income societies. But above all, beyond Succeed, there's life. And therefore, whatever we do right now with our stakeholders and partners, it has to be sustainable. And we are hoping that by the time we come to the 6 years line, we will be able to establish tangible mechanisms which enhance and promote the welfare of people with psychosocial disabilities. And with that, it cannot have come at a better time than now, when our focus is on inclusivity of everyone in matters of development. Therefore, it is my gratitude to all of you for joining us this day as we announce our launch, and we hope to be able to leave a significant mark from today and beyond. Thank you very much once again for joining us.
Thank you very much, Lloyd, for that holistic speech on the holistic nature of people's needs and shift from purely medical perspective. We are extremely delighted that Dr. Florence Baigana, the World Health Organization mental health technical focal point for the Afro region, has sent in a video where she will be speaking on why this research is needed in Africa, an alignment to WHO principles, frameworks, ECT. So let's have Dr. Baigana's video, please.
Hello, this is Florence Baigana, WHO Africa, Regional Advisor for Mental Health and Substance Abuse. I'm very glad to be here with you today. While not here physically, but I'm still here with you. In a sense, I was not able to attend, but I've been closely following the process. Succeed is something that we as WHO Africa region believe is going to be very important for the work that we plan to do. Some of the questions that I believe Succeed will be responding to are issues like what does CBR in the Africa region involve? How do we lessen the burden for care, for carers and for people with lived experiences? How do we lessen that burden of care? Because often when we say we are providing community-based rehabilitation, it's often transferring that burden of care onto the carers, onto the parents and others who are looking after somebody or providing support to somebody with a lived experience. And what is the place of CBR, of community-based rehabilitation, in community mental health programming? How do the two fit together? Do they complement each other? Are they going to be catalytic and not competitive? It's going to be interesting to see what comes out of the Succeed project, especially the evaluation piece. In the Africa region, as we work to strengthen community mental health services and services provided at the primary care level, the results coming out of the Succeed project are going to be very, very important to us. We hope that the project will be able to generate evidence that we can then use to scale up or replicate similar programs in other countries in the region. I want to congratulate very much the members of the consortium and to say that WHO Africa region is very happy to be on the consortium advisory group of Succeed. Thank you very much.
Very briefly before I think Drick Mulia comes up, please, we have a time for questions and answers. So I think we can start to post our questions or think up our questions. We have a lot of time where you can ask questions on the platform. So, and I think that would be coordinated by Dixon. Thank you.
Thank you. Go ahead, Dixon.
All right. Thank you all. And Olayinka, thank you very much. So there was one question. So just as a way of introduction, I am Dixon Chibanda. I'm from Zimbabwe, and I am the regional lead in this part of Africa for Succeed. There was one question about CBR. What is CBR? And I think one of the challenges with big programs is you tend to have a lot of abbreviations as you speak, and there are people who might not be familiar with some of the abbreviations. I think Lloyd mentioned CBR, so I'll leave him to explain what CBR is before we move further. Please go ahead, Lloyd.
Thank you very much, Dixon. So when we speak of CBR, we are talking about what we call community-based rehabilitation. And this is a process where we are saying when we deal or when we manage psychosocial disabilities, we do not have to take, for example, people with psychosis out of the community so that we seek to assist them. But we are saying the challenges that they encounter, they also need to involve the community. Mind you, when we talk of community, it's a very broad term. We are even talking about the policymakers. We are even talking about those who surround them at the family level. So for that end, you want to understand, to say, okay, when you want to work with the people with psychosocial disabilities, what are some of the challenges that are encountered even at family level, so that the family that offers care to these people is also given an opportunity to say, you know what, when we work with people with psychosis, some of the challenges that we face with them are ABC, and we think the way to address those challenges is ABC. Then we also say, okay, if that needs to be done, how does it change in relation to policies? And then we have voices coming from policymakers. So essentially, when we talk of community-based rehabilitation, we are speaking of the need to involve everyone in a manner that speaks to sort of a bottom-up approach of managing psychosocial disabilities as opposed to a top-down approach. I hope that helps. Thank you, Dixon.
Thank you. So there's another question here from Angelica, who is asking, she says, my name is Angelica, I'm from Zimbabwe, founder of the Zimbabwe OCD Trust. My question, I suffer from obsessive compulsive disorder, and in Zimbabwe and most of Africa, this disorder is hardly spoken about. And from my experience, this is a debilitating disorder, and I feel more should be done in terms of awareness and research. Is Succeed going to include this in the program? Julian, do you want to take that?
Thanks, Dixon. When we were thinking about this program, we thought long and hard about what we would focus on. In fact, we didn't want to start from a perspective of diagnosis. We wanted to really think about more holistically around the way that people are affected by mental health problems. But we decided in the end that we really wanted to focus on a certain set of conditions, which you've heard about already, that are actually extremely disabling. That's psychotic conditions. But there is less work that has been done in research in that area than in some other areas. I'm afraid that that meant that we had to take some decisions about what we were going to focus on, because of the type of work that we plan to do really demands some clarity of research questions. So we're not really going to focus on OCD, but I do think that it's important to recognize that a lot of the research we do, a lot of the lessons we learn, and the publications that we make will have application more broadly than just in relation to psychosis, because we recognize that there are many commonalities in the experiences of people with a variety of different mental health problems. And I think that what we learn can be applied to a broader range. But I'm afraid we did have to make some difficult decisions and decided to really focus on that particular group of people with disabilities associated with psychotic conditions.
Thank you very much, Julian, for that response. I hope that is accepted. The next question is from Gergana Manolova. do you already have some overview on the findings from the systematic reviews on what works on co-production? And how do you plan on engaging stakeholders from the community of people with lived experience in the 4 countries? I wonder if Grace would not want to take that, and maybe Tom as well.
Great, yeah. So we had a really incredible student, Cece, who ran a kind of rapid review on what works in co-production for people with psychosis. And this wasn't limited to low and middle income country settings, because frankly, there's just this very little from low and middle income country settings that's been documented, at least in the published literature, for us to learn from. And one of the sort of troubling findings is that while co-production is increasingly considered, a best practice sort of approach to improving patient and public involvement in mental health research, people with psychosocial disabilities are oftentimes even left out of those activities. So there's almost a stigmatization even within this field, where people with psychosis are among those most likely to be left out of any kind of user involvement activities in research and service design and all those other good areas. So I think one of the sort of disturbing findings is that there actually wasn't nearly as much as we expected, even from high income country settings. And that, of course, as is often the case in this area of research, the quality is often quite poor, with sort of limited standardization in terms of what is called co-production and what are maybe, including techniques that don't always really fulfill that spirit of co-production that we're trying to embody. So that should be coming out in a couple of months. But I think the unfortunate answer is that it probably isn't going to answer what works in co-production for psychosis. It's probably going to point to things that work that aren't actually co-production, but call themselves co-production. And then this question on engaging stakeholders with lived experience, I think that's a good question for some of the countries, but also perhaps for Julian, who's been kind of taking a leadership role in organizing the advisory structures at the different levels of the consortium.
I'm
Thanks,
actually going
Grace.
to talk about that in a few minutes after we finish these questions. So if it's okay, I'll leave it till then to talk about those structures we put in place.
Great.
Sure, that's fine. Tom, would you like to add on to that, to what Grace has just said?
I think that it's a bit soon, because we're obviously involved in the systematic reviews at the moment. As Grace says, we do have the systematic review of grey literature on CBR, but I would like to wait and see the results of the systematic review on psychosis and on published literature on CBR before really commenting. What we're doing today is launching a 6-year process. We really want you to be engaged with it, to come back, to watch this space, as it were, and see what we're finding. We're going to be publishing evidence briefs and papers, and we really want to communicate with this community so they can uptake, as it were, our findings and apply them. And we will have this theory of change approach, which means firstly training on how to do theory of change process, and secondly meetings in all of these countries that you see represented today, so that we can have a genuine understanding of what the barriers are, what the possibilities are, and where the emphasis needs to be placed in different countries, and have an evidence-based and collaborative process in moving forwards.
Thank you very much. We have several questions, so maybe we need to be, I'll kind of restrict how much time I give you in your response so that we try to go through as many of these questions as possible. The next question is from Dr. David Kripes, sorry if it's wrong pronunciation. And the question is, how will Succeed ensure that the voices of people with lived experience and those of carers are both supported independently, particularly when they differ? Maybe Anthony, Rebecca, and Olayinka can respond to that. Can I give you like a minute each?
So who do you want to go first?
Well, you can start since you've spoken first.
Okay. one of the things that we are doing is that we realize that persons with lived experience are an integral part of everything that we are doing. On the Nigerian team, for example, we have 3 pair researchers, 1 full-time, and they are engaged with every single thing that is done. And the other thing we realized, particularly in the Nigerian team where we are focusing on youth, and also because of the peculiar support in most parts of Africa, caregivers are the social welfare. We don't have proper social welfare systems from the government. So we are engaging with carers. So even in the research we were doing about young people's experience with COVID, that is people with severe mental illnesses, we're also doing a similar study on the caregivers. And not only that, on our local advisory group, not only do we have persons with lived experience, but we also have caregivers, because we understand very much that both persons with lived experience and caregivers are an integral part of anything we're going to do. They need to contribute, they need to be at the center of all we're doing, because it's all about them. And it's important that their voices get heard the loudest. Thank you.
Yeah, and just to add on what Olenka said, for example, in Malawi, we would like to make sure that even in our team, the researching team, has people with lived experiences so that their voices can be heard. We just don't want to document experiences, but they should tell us how they feel, how they've been treated following suffering from psychosis. But again, we have engaged an organization which is Mehuka, which is an association for the mental health users in Malawi, so that they are actively involved as we are conducting this research. So they will be collecting the data, but also these are individuals that have history that they suffered from psychosis. So we want as much as possible to make sure that the voices of people with lived experience is heard throughout the research pyramid. As we are developing the research findings, they should have a very, very beautiful input into that. So that's what we are trying to do, to make sure that people with a history of psychosis have not been left behind. Thank you.
Thank you, Anthony. Rebecca, is Rebecca present? Okay, I think I will move on to the next question, which is from Aquila Vera. Hello, Aquila, how are you doing? And Aquila's question is whether we intend to address the difference between support and treatment, because many times in Africa, people are given support, but no actual treatment. I will leave this open to any of the Succeed team members who want to respond to this question. Any takers?
Well, I am just trying to understand. A lot of times, there's a big overlap. Many times, the kinds of mental health conditions we're dealing with, what you are doing is it's the more of management, because you may not necessarily have a cure, but you are trying to do the very best to make sure that every aspect, there's a holistic program in place, biological, psychological, social, so that every aspect of the person with a lived experience life is taken care of. And that's why we may not necessarily use the word treat, we may talk about management. And then also, we can talk about psychosocial support, supporting them socially, psychologically. And I think that's why we may have those terms which we use. rather than treatment, we use the word support and management. I don't know if that's helpful.
Mm-hmm. Thank you. Anyone else wants to add?
Maybe I could just comment on this briefly. I think we see that access to health care is important. And what we don't want to convey is the idea that because we are prioritizing a broad range of social supports that people find important, kind of rights-based approaches to supporting people with psychosocial disabilities, that we are suggesting in any way that treatment is not important. I think that might be what's behind this question, because there has sometimes been a tendency to say, well, either psychosocial support is important or treatment is important. And we completely recognize the fact that in many African countries, the treatment gap is huge. A very small proportion of people have access to health services. And it's not something that we're going to deprioritize in any way, while recognizing it is only one part of a range of things that people might need in order to be able to flourish in their communities. But we are certainly not making it less important than people often say when asked what matters to them. They say treatment, access to treatment is really important when it's not available.
Yes, thank you, Julian. Thank you. I'll move on to the next question coming from Blessings, who is asking, Blessings Chikasema, who is asking about scaling up Succeed. What plans do we have to ensure that the good work that you're going to be doing, it will actually eventually be scaled up? And I guess, again, this is really open to the whole team. Tom, do you want to start maybe by responding to that, to the whole question? I guess this is more linked to sustainability. How sustainable is the work that we're doing going to be post the funding period?
I think that we're going to hopefully be sustainable and have a wider scaling up influence in a couple of ways. First of all, we're going to publish really good co-produced evidence, and there is a lack of papers on the basis of co-production that are relevant to mental health in Africa. So we will help with that, as will Amari, the program that you're leading, and the other wonderful programs like Upsides and so forth that have a relevance to Africa. So that is one contribution which will always be there and which we hope will lead to further uptake. Secondly, through this program, we're going to train a lot of people with and without psychosis to do this work. So those people will still exist. And what we really hope, we won this money from our friends at FCDO. What we really want is next time round, we don't lead the bid. The people you're listening to today lead the bid, and that they are funded through UK aid and they're able to continue this work. We're not trying to create work for the London School. We're trying to have South-South collaboration. So there's a body of people with capacity to continue this work, particularly around co-production. And thirdly, while we're working in 4 African countries, clearly what we're doing is relevant to many, many other low and middle income countries, and quite frankly, to high income countries like Britain as well. So by demonstrating what difference it makes to people's lives, by demonstrating how people can live better with psychosis, we hope that we're showing something that others can take up. We have limited money. We're going to be here for 6 years. We're not going to be here forever, but we hope to leave a legacy that other people are not starting from scratch, but can continue, we hope, the good work that we've achieved.
Thank you, Tom. I just want to add to that, Blessings, to your question. I think one of the strengths of Succeed is the fact that policymakers and other key stakeholders who are instrumental in integrating any kind of initiative in existing public health programs are going to be part of Succeed. And also we have several other programs that we intend to partner with, like the African Mental Health Research Initiative, which will strengthen the research component. So there are quite a number of things that Succeed is thinking of. I'll move on to the next question, which is, and I think this is a very important question, at least for Zimbabwe, and I believe for Malawi too. This is from Shaza Dos, who asks a question on treatment of persons or inmates in prisons with mental health challenges in low and middle income countries. We know that some of the worst human rights violations for people living with mental health, particularly severe psychosocial disabilities, happens in these institutions. So how will Succeed be responding to this? Maybe I can ask my colleagues from Africa to respond to this question. Olainka, would you like to take that one?
Yes, I actually think that a lot of the interventions that would come from this project, this research project, would help not reduce the treatment gap. And the treatment gap we've recognized is all over, not just people in their homes, but also those who are in prisons, those who are in the juvenile justice system. So I believe that there would be a cascade effect of this. Once we have the evidence in place and we have fantastic local advisory groups with policymakers, with caregivers, with persons with lived experience, then the voices will be louder. And then we can now get into all these places where there are people who may not necessarily have access to mental health care. I can speak for our own center, our own group. We are very fortunate that already we in the Ibadan team have an inroad into the juvenile justice system. So for many years, we have worked with the juvenile justice system. And also in our department of psychiatry, we already have links to the prisons. So on a regular and consistent basis, we have mental health professionals reaching out to those in prisons. It's an integral part of the work we're doing in our department in Ibadan. And that brings us, and we know that those aspects will be incorporated into the work we will be doing with Succeed as the evidence becomes more and more obvious. Thank you.
Thank you very much, Olenka. Yeah, go ahead.
Yeah, Dixon, I just wanted to add on from where Olenka said, as regards to the question that is talking about the prison. Just wanted to add that indeed the whole purpose of Succeed is also to bring out issues in mental health, because there's very limited research that is happening across Africa, and in this case, particularly Malawi, that is talking about psychosis and its effects and how it is affecting people. So our hope is that once we do this research, which is already engaging the policymakers, and once the gaps are, laid bare, the policymakers then will see the need to address issues that are happening, for example, in mental health issues that are happening in the prison, because unless somebody is able to document these issues, they remain, scattered and nobody pays attention to them. So one strength of Succeed is that it's going to bring evidence out for policymakers to see the need now to scale out mental health care services to vulnerable groups, which one would be like others in the prison and the other, vulnerable groups as well. Thank you so much.
Thank you. Thank you, Anthony. The next question is coming from the Zimbabwe team, and it's linked to the role of traditional healers and faith healers. In most of Africa, people with psychosocial disabilities, particularly severe psychosocial disabilities, often the first port of entry is a traditional healer or a faith healer. A study by Burns from South Africa showed that up to 80% of people needing services will initially visit a traditional healer or a faith healer. How is Succeed going to work with these alternative therapists who are very common in Africa. Maybe Anthony and Olainka, you can take that. And I'm
okay.
Yeah. Okay. Okay. Go
Thank
on, Anthony.
you.
Yeah.
Okay, thank you, Dixon, and thanks for the beautiful question about the traditional healers. In Malawi, under Succeed, what we intend to do is that when we start training our CPR teams in the districts that we're going to carry out the research, we will engage the traditional healers and involve them in the training so that they can also contribute in terms of enriching our findings, because we know, as you have highlighted in your court, that in fact, when we are studying pathways to care in mental health, almost 80% of people affected with psychosis, their first point of call will be the traditional healer. So we want to engage them as well in the Succeed project that we'll be doing here in Malawi, so that they can learn how to care for these people, but also deal with particular issues of stigmatization, because they can sometimes start right away at the traditional healer's place. So we want to make sure that they have right information, but also they are taken as part of the care team when it comes to mental health issues. Thank you so much.
Thank you. Olainka, do you want to add on to that?
Well,
Very
just,
briefly.
just to say very brief that our local advisory group consists of a very wide range of people. We have traditional healer, we have faith-based Muslim clerics, Christian clerics, traditionalists. So that apart from lived experience. So that's one of the ways in which we're going to ensure that we're all carried along. Thank you.
Thank you very much. I can see that it's almost 3 o'clock or 2 o'clock. There are several questions. I think the other questions can be answered through the chat. Shall I hand back to you, Julian? How would you like us to proceed?
Thank you very much, Dixon. That's great. I think we do need to start wrapping up. So maybe if some of my colleagues can be answering those questions by typing into the box on Zoom. I just wanted to use the last couple of minutes to explain to you a little bit about, as well as the participation of peer researchers, we also really wanted to make sure that we institutionalized accountability to people with psychosocial disabilities. And learn together moving forward about how to do co-production well. So we have a number of different bodies that have been established at different levels, at national and international level, and across the whole program, to make sure that people with lived experience, particularly where they exist, local organizations that represent people with psychosocial disabilities, are able to contribute to Succeed in a very meaningful and live way as we move forward through the whole process. I also want to acknowledge that on this call, in fact, on this webinar now, are several members of our scientific advisory group, who are members of our consortium advisory group at an international level, along with the WHO, who we heard from in the person of Florence Bangana, CBM International, and McPin, who are experts in co-production and participation of people with psychosocial disabilities in research particularly. So I'm not sure if they're all on the call, but Sumit Jain is a doctor who works in co-production and has a lot of experience in CPR type interventions at the University of Edinburgh. Crick Lund, who works at the University of Cape Town and at King's College, was actually the CEO of Prime, a previous DFID funded program similar to this one. Dr. Tara, who many of you will know as a global expert in schizophrenia research, who has been running a very long cohort in India at SCARF, and David Crepaz-Kie, who I know is here because he asked a question, who's at the Mental Health Foundation and an expert also in participatory approaches to research. So we have a really fantastic body of people who will be able to make sure the research we do is really cutting edge and on the right track and very participatory. So that really leaves me to thank everyone who participated today and thank everyone who came along today. I hope you are as excited as we are about this great opportunity. We're very grateful for FCDO in really putting into practice some of the principles that are at the heart of their theory of change and approach to mental health within FCDO. And we are really looking forward to learning together, moving forward, how we can really fundamentally change not only the way that people can access care and support in low and middle income settings, but also that we can really learn how to do research better in a very participatory way. So thank you very much to all of our speakers. I think you did a really fantastic job of conveying what we're trying to do here. And for those of you who've come along today to listen to what is happening with Succeed. You can find out more by getting in touch with us at succeed.uptake@lshtm.ac.uk, or we're going to be working a lot through the Mental Health Innovation Network and particularly MHIN Africa. So that's also a good place to find out more about Succeed, but you'll certainly be seeing much more as we move forward. Thank you everyone for your participation.
Good.
Thanks, everyone.
Bye-bye.
Thanks, everyone. Bye.